Okay, I'm going to start the webinar in 3, 2, and 1.
Hello, everyone. We'll just wait about 10-15 seconds for people to log in, and then we'll get started. Okay. Hi, everyone. Welcome to our webinar, Managing Side Effects from Surgery, Chemotherapy, and Immunotherapy for Uterine Cancer. I'm Kitty Silverman, the Uterine Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, please visit our website at sharecancersupport.org. Just a few housekeeping things for tonight. All participants will be muted during tonight's presentation. When the presenters are finished, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat section will be disabled. When asking questions, remember that the presenters are unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speakers. Erin, Reese, and Kathleen Lutz have been women's health nurse practitioners since 1998 and are currently both nurse practitioners at NYU Langone Medical Center. They joined the Gynecologic Oncology group there in 2009 and have been caring for gynecologic cancer patients since then. They have a multifaceted role in caring for preoperative patients for cancer surgery, during chemotherapy, post-chemotherapy, cancer surveillance, and also help manage all side effects. They also actively manage patients that are enrolled in clinical trials for the treatment of gynecologic cancers. They are both members of the Society of Gynecologic Oncology and have presented many community talks on gynecologic cancer. I first met Kathleen and Erin in 2014 and have had the great pleasure of working with them over the years. Welcome to you both, and thanks so much for joining us.
Thank you, Kitty. Thank you. Hi, I am Erin Reese, and this is Kathleen. Hi, and I am going to share my screen now. Yeah. So hopefully everybody is able to see this at this time. I'm focusing on managing some of the side effects from surgery. Kathleen's going to talk more about the chemotherapy and the immunotherapy options for uterine cancer. So cancer is when, a general description, cancer is when the cells in our body grow abnormally. In terms of uterine cancer or endometrial cancer, which is the cancer that is within the lining of the uterus. It is the most common gynecologic cancer, and about 85% of women with endometrial cancer diagnosis will survive, and that's because of early detection. The majority of women are diagnosed as a stage 1 cancer, and we know that that greatly improves survival. Generally, the risk of endometrial cancer will occur at around the time of menopause, but we do have, unfortunately, several young women who are also at high risk. And when we're talking about endometrial cancer, we're thinking about what are the things that can lead to this diagnosis? What are those risk factors? First and foremost, we know that obesity increases the risk. Women who take what we call unopposed estrogen, or it is estrogen without additional progesterone, which does help protect the lining of the uterus. There are other comorbidities or other health factors that increase the risk, and that includes diabetes and high blood pressure. Women who have breast cancer or a high risk for breast cancer are often prescribed tamoxifen. And those women do have an increased risk for the development of endometrial cancer. As we get older, generally the average age of menopause is around 52. So the older that we get, the more risk we are for developing this type of cancer. And about 75% of women will have already gone through menopause. So again, it's keep in mind that the most common risk factor of endometrial cancer is obesity. And that's because we know that within our fat cells, we have higher circulating levels of estrogen. This is a really important thing for us to pay attention to. And one of the things that Kathleen and I have, when we've done community lectures, have really focused on abnormal vaginal bleeding. This is especially the most common symptom that we see women presenting with endometrial cancer is they've had abnormal, often irregular, heavy bleeding or bleeding after menopause. Vaginal bleeding after menopause is never normal, and we encourage all women to, make note of their body, make note of changes, and seek professional help from their healthcare provider, gynecologist. A watery pink or a white discharge that consistently comes from the vagina, especially after menopause, it needs to be investigated. Paying attention to other symptoms may include persistent pain, particularly within the lower abdomen or the pelvic region. Pain during sex should be evaluated as well. But I will say the number one side of symptom of uterine cancer would be abnormal vaginal bleeding. How do we treat uterine cancer or endometrial cancer? Primarily, the most common treatment is going to be surgery, and that is going to be a hysterectomy, which would include, the standard procedure would include the removal of the uterus, the cervix, fallopian tubes, and the ovaries. There are always complications and side effects from any medication, any procedure that is performed on a patient. And the possible complications that occur from this surgery could be an injury to the intestines or bladder, a fistula formation, which is just an abnormal connection between tissues, a vaginal cuff dehiscence. And what that means is after the uterus and the cervix have been removed, you have an incision within the vagina. Sometimes that incision, especially with other comorbidities, or if it just did not heal appropriately, can what we call have a dehiscence or an opening or separation. And then pelvic organ prolapse, especially we see that with like the bladder, it loses some of the support. The most common thing that women want to know is what is going to happen in their body after surgery. The majority of the women that are having these surgeries or this diagnosis have already gone through menopause, so they may be quite familiar with some of those postmenopausal changes. What does it mean to be in menopause? What are the most common symptoms that we see? We refer to them often as vasomotor symptoms, and that would include some hot flushing or hot flashes. They're often instantaneous, quite uncomfortable. Night sweats. Women often report that they wake up in the middle of the night feeling very warm. This also may be short-lived. That's the hope. We often see weight fluctuations, skin changes, and that includes dryness and the thinning of skin and insomnia. All of these are very common and often treatable symptoms that can come with menopause. And then there are also often mood changes. Women often report that they're feeling more irritable, nervousness, anxiety, and depression. We see that quite a bit. It's pretty hard, pretty difficult to get a diagnosis of cancer and then to be put into what we would call a surgical state of menopause. is often incredibly challenging. Reduced libido or reduced sex drive, we often see this as well. And you can see where some of those other symptoms of menopause would be a cofactor in this. When you're having night sweats, when you're anxious, having irritability and depressed, all of those things are also going to impact your libido. Fatigue, surgery, a cancer diagnosis, everything is incredibly tiring. And this also can affect memory and staying focused. Some other, one of the big things that I try to focus in on my practice are the urogenital symptoms, which would be what we call vaginal atrophy or dryness. And this causes quite a bit of discomfort with sex. It also can lead to frequent urination, and frequent urinary tract infections are also associated with this dryness because that tissue has become thinner and it's less supportive. Again, some of the other things that I'm going to talk about would be, what are the long-term effects of menopause? Our hope is that often the most common symptoms, the menopausal symptoms, things like that can be addressed, or also that they are short-lived. But there are some longer side effects of menopause. And one of those would include osteoporosis. So that is bone loss or bone thinning. And this increases our risk of fractures. And we know as we get older, that also increases our risk for fractures and falls. So it's really important that we are, as healthcare providers, that we're monitoring our patients' bone health. And that includes often using what's called a DEXA scan, which is an X-ray. And we typically, with our patients, will monitor it every few years, depending on if the patient has other risk factors. Sometimes patients are going to require treatment with a medication. One medication that's
close the door. I'm in a meeting for work. Close the door, Chelsea.
One of the common treatments would be with a biophosphate. I can't pronounce anything. It's 6 o'clock. Some of the brands would be like Clozamax, things like that. And these medications can help with this. We often refer our patients to a bone specialist here who may advise treatment with those medications. I'll talk a little bit more about this. I'm very pro exercise. We know that exercise, especially weight-bearing exercise, helps protect our bones, helps build our bones. That may include some weight training, walking, running. It can be a variety of things. And then even things like yoga. Although yoga is not weight-bearing exercise, it helps with stability and balance. And that can help reduce the risk of fractures. Another big long-term effect of menopause may be heart disease. Estrogen, it helps the blood flow more easily through our arteries. After the time of menopause, we may see an increase in blood pressure and elevation in cholesterol. This may warrant that if patients previously were undiagnosed with high blood pressure, they may need to take something for that. They also may need to take a cholesterol lowering medication as well. In terms of heart disease, when you're thinking about the risk of surgery and treatments for uterine cancer, it's really important to know that there are things that we can do. We can eat healthfully. We can get daily exercise, and we know that those two things may help decrease our blood pressure. A healthier diet can improve our cholesterol, but you may need additional help. And this is important because there is an increased risk of a heart attack during the first 10 years post-menopause. And so anything that we can do to help promote heart health, which heart disease is the leading killer of women, incredibly important, and something I know that we are constantly talking with our patients about. And I I really just encourage women to take a moment and just stop and think. If you are not taking care of you, you are unable to take care of other people. So really adding in an exercise program into your life, making healthier food choices, limiting alcohol. Please don't smoke. If you've been diagnosed with cancer and you're a smoker, we have programs here. We're really fortunate at the institution that we work at. We have a fabulous smoking cessation program. But things like the American Lung Association, there are a lot of supportive programs. There are a lot of medications that also can help promote wellness for our patients. I know I've spoken a lot about exercise, balance, yoga. Sexual function is incredibly important for our patients. If they are currently sexually active or not sexually active, we will often speak with them about things like vaginal moisturizers. The design of a vaginal moisturizer is to help promote moisture to your tissue. Very similar as if you're using like your oil of Olay on your face. We want to promote good moisture because not only can it help make sex more pleasurable, but it also can reduce things like urinary tract infections. If a woman is sexually active, whether it's with a male or a female partner, incorporating the use of a lubricant into their sexual practice is often highly recommended. Again, sex should not be painful, and there are things that we can do. And I encourage women to talk to their healthcare provider about what are the best options for them. And then also, I spoke just very briefly about the common things that can happen with menopause. In terms of anxiety, depression, irritability, but you throw on top of that a cancer diagnosis, and getting support for yourself is incredibly important. And that is why Kathleen and I were excited to do this talk tonight with Share. Share has the experience, they have the foundation, and being able to offer something to our patients is incredibly meaningful. I'm just going to briefly also just talk about, in terms of the menopausal symptoms, and especially vaginal and sexual health, we do prescribe for the right patient some estrogen replacement therapy. And again, I'm saying the right patient. Especially our younger patients, they need the hormonal support. Again, we're looking at the big picture. We're looking at the whole person, including bone health, heart disease prevention. Those patients post-hysterectomy may be a really great candidate for some oral estrogen. Quality of life is incredibly meaningful as well. In terms of estrogen for the vagina, there are multiple options that are available. We commonly prescribe a tablet. It's actually a vaginal tablet that goes into the vagina, typically at night, and it really provides localized support to the vagina. There are also some vaginal estrogen creams that are available, and they do the same thing. Some women are more comfortable using a cream option because they can also apply a little bit to the outside of the vagina as well as to the inside of the vagina. And I just encourage our patients, the participants in tonight's program, to really speak with their healthcare providers. There is help available to help treat the menopausal symptoms that are associated with the treatment of uterine cancer. And now I'm going to hand it over to Kathleen.
We'll take a stretch break, everybody.
Yeah, everybody, yes.
Stand up, spend 15 minutes of sitting, right? Everybody stretch for a minute, take a deep breath. We're gonna switch chairs.
We're gonna switch chairs, and feel free to do push-ups, planks, yoga poses,
Jumping jacks.
anything you need to move your body.
Yep, we'll just grab my water. All right. So Erin, thank you so much for starting us off tonight. That was amazing. And, kind of a good overview, about the surgery. There's a lot to know about the surgery. What's going to happen to my body. So I'm sure you guys are going to have lots more questions that hopefully we can answer for you, towards the end of tonight's talk. Well, what's important is what people already know. What stage am I in? You know, and it's hard to kind of break it down. This is a very kind of simplified slide talking about what does staging mean? Well, it basically means where the cancer was spread to besides the uterus. So what we look at is three different things. We look at the extent or the size of the tumor. How far was the cancer growing into the uterus? Okay, and we measure it in centimeters or percentage. And when we get our pathology reports, oftentimes we will be able to say, okay, it's less than 50% or it's more than 50%. And that's going to help guide us onto what the next step is. Then the next part is nearby spread. Did it spread to any of the lymph nodes that your provider has, now removed? So these are what's called the para-aortic lymph nodes. They're low down in the pelvis. They're in and around the aorta, which is the main artery that runs, from the heart, down back into the abdomen and pelvis. So you'll often hear the term lymph node dissection or sampling of your lymph nodes, because we want to see, has the cancer cells spread to any of the lymph nodes in that area? Then the last thing is M, distant metastasis. Has the cancer spread to any distant lymph nodes or any distant organs in any other parts of the abdomen or pelvis, at that point? And during the surgery for uterine cancer, that's everything that's looked at. So like Erin talked about the surgery, it's removal of the uterus, the fallopian tubes, the ovaries. And when I say uterus, I mean uterus plus the cervix, the ovaries and fallopian tubes. We sample some of the lymph nodes in that area in the lower pelvis and lower abdomen. And then we look for any of the sites of distant metastasis. So the provider will, be examining fully your abdomen and pelvis to look for any areas that might need a little sampling. So on a pathology report, you might see a lot of different biopsies, and what we want to know are any of those positive. And nowadays, I know at NYU, and I don't know about with other institutions, reports are automatically released. I think it's the CARES 2021 Act. So results are released to patients before we even see them sometimes. So there's a lot of panic that goes on. But now hopefully, if you have to go through this, or you have a family member or a friend that's going to now go through this, and they get that report, maybe you'll have a little bit of information to help kind of calm their fears until their provider can kind of reach out to them. So the staging is important because it helps us decide where the cancer was spread to besides the uterus. And there's other things that also help us decide, what else comes next. But the staging is the first part, and we are able to get that after the full pathology is reported and kind of, broken down into, like I said, the size of the tumor in the uterus, how far was it spread? Does it spread to the lymph nodes? Are there any distant metastases, meaning spread to other organs or other parts of the abdomen or pelvis? And we know that the majority of uterine cancer surgeries are done what we call minimally invasive or laparoscopically. I'm sure you've heard the term robotic hysterectomy. Many of our providers now we've come a long way from when we started doing robotic surgery to now most of our uterine cancer surgeries are done robotically or laparoscopically. What does that mean for recovery? It means you're going to be out of the hospital a lot of times in the same day, or if not the next day, and your recovery is going to be improved, and there's been shown to be less pain, and patients can quicker, get back to work when they have to, or get started on treatment if they have to. So how do we know if I'm going to need treatment for my cancer? That's maybe my next question. So we want to know histology. Well, and why is this important? Well, histology identifies the exact cell type of the cancer. And it's important to help us decide if your cancer is high risk and what treatment may or may not be indicated. So I just kind of put down a few histology types that we most commonly see in uterine cancer. Now, if somebody's on tonight that had something else different, please share with us. We can always talk about it. But endometrioid is the most common type that we see. And when I see a patient like this, I say, well, I'm not going to simplify it for you, but it's the most common. It's the run-of-the-mill type. If you had to have a cancer, this might be the one, because it's typically found early and early staged, meaning it's typically confined to the uterus, and it's typically one and done, meaning you have your surgery, you recover, and you don't need any more treatment in the majority of the cases. Now, there are some cases where endometrioid spreads beyond the uterus, and then sometimes, treatment might be indicated. Now, some of the higher risk types, and if you're out there and have any of these or had them or know somebody that did, we call it the serous type or the clear cell type or sarcoma or carcinosarcoma. So on your pathology report, you'll be able to see what that histology is identified as. And that actually helps us decide what the next step might be in terms of, is your cancer high risk? First, what stage is it? Did it spread outside of the uterus? Did it spread to other sites? And was it affected in any lymph nodes? And what's the histology? What's the cell type? What makes you high risk? So we kind of put patients into categories by following an algorithm, so we can help decide better if we're going to need further treatment or not. So some of the common histology types: endometrioid, serous, clear cell, sarcoma, carcinosarcoma that we see. So what's some of the treatment for uterine cancer? Well, there's what's called neoadjuvant chemotherapy, and that would be chemotherapy given prior to surgery. Do we see patients like this? We certainly do. They come in with advanced disease. Many times it's related to the sarcomas or carcinosarcoma, and the disease has spread already beyond the uterus just based on imaging tests, which can definitely help us sometimes. It's maybe spread to other parts of the abdomen or pelvis or even the lungs. At that point, it's felt that chemotherapy would work better first to try to shrink the amount of disease and then consider surgery after some time. The most common type of treatment in uterine cancer is called adjuvant chemotherapy. And this is when chemotherapy is given after surgery. And it's a curative intent at this point, because in most cases, all the visible signs of disease, meaning all the organs plus any other visible signs of disease, have been removed. And you almost start, like I sort of say, it's starting from ground zero again. Like, you've had cancer, it's now gone, and now we're going to give you chemotherapy. Well, then your next question is, well, if the cancer's gone, why do I need chemotherapy? Because we know in about 66% of patients, there's still microscopic cells in there. And the whole purpose of chemotherapy in uterine cancer in the advanced and high risk, histology types are to prevent it from coming back. And that's where we're at when we've given adjuvant chemotherapy to patients where all disease was removed. So the treatment for uterine cancer, common chemotherapy used, Taxol or paclitaxel and carboplatin, that's the gold standard. I'm sure people online tonight who have had uterine cancer or know of somebody treated with uterine cancer knew that they were treated with Taxol, or the other full name is paclitaxel and carboplatin. And it is the gold standard. It's what's been used in the majority of our studies. And patients do well. They really do well. Certainly, we take into account patients' age, other comorbidities or medical problems that they might have. What else do they have going on in their life? What other side effects they might have experienced in helping us decide dosing. I can get into that a little bit in a few minutes. But the gold standard in uterine cancer treatment is Taxol and carboplatin. What are some of the adverse events or side effects? And you'll hear the word adverse events, or if you're anybody out there reading any kind of research articles, they talk about AEs, adverse events. What are some of the side effects that patients may experience from Taxol and carboplatin? We start with the number one thing that I always talk about, and I start with from the beginning when I'm talking to patients and counseling them on chemotherapy, is hair loss. And I think it's at that point, everybody stops, everybody kind of takes a deep breath, and then a lot of people cry. And I think it's normal reaction, because when you think about it, losing your hair is the most visible signs that you might be sick. And it's a loss. Our hair is a part of us. It makes us who we are many times. So sometimes when you first hear that first time when you're in the provider's office, it's often one of the hardest things for me to say to somebody is that you're going to lose your hair. And then I could say that your hair will grow back. I've had everybody's hair grow back who I've treated. It may grow back with a different consistency, a little different color, so forth and so on. And there's a lot of things out there to do. There's wigs, there's scarves, there's hats. We talk about that with our patients. We refer them to, there's a place in the city that specializes in wigs. It's called Underneath It All. It's near the Empire State Building. One thing I am going to say about wigs, what we've learned of recent is that insurance companies don't really cover the wigs anymore, from what we've learned. Many patients will come back and say to us, well, I need to get prior authorization for a wig. And luckily our nurses go to great lengths to try to make that happen. It's not always possible. What we tell patients when they do want to go for a wig is to get a prescription from their provider, and they can submit it to the insurance, and maybe some of it will be covered. If somebody, you know, somebody that might not have the means to get a wig, you can get wigs through the American Cancer Society and other cancer support groups. Hats and scarves, things like that. But again, it's one of the most visible signs. So I think one of the hardest things that we, you know, sometimes talk about. Will I lose my eyelashes and eyebrows and my pubic hair? Yeah, you probably will. They tend to happen a little bit later on as you're going through chemotherapy, but they do fall out too, and they will grow back. Luckily, makeup nowadays works wonders for fixing some of those things. Patients have come in with all sorts of fake eyelashes and eyebrows, so learning a lot from all of that too. What's the next thing that we talk about with chemotherapy? Am I going to be tired? You are going to be tired. The majority of people that we see with uterine cancer tend to be on the younger side, you know, 50s, 60s. If you're someone that's relatively healthy and has led an active lifestyle, you can push through the fatigue, you can get through. There'll be definitely days where fatigue is more than other days. On average, how we counsel our patients is day 3 to 5 after your chemotherapy is when the fatigue may hit the most. And then hopefully you're going to tell me by day 5, 6, or 7, you're on the upswing and starting to feel better. I tell my patients, the biggest thing you can do is stay active, move around. If you can, exercise, even take a walk every day. Any little bit can help fight the fatigue by staying active and exercising. And Erin talked a lot about exercise for menopause. So even with menopause and then the adverse events from chemotherapy, the fatigue can be fought in such a way that you can get through it. Certainly, I say to my patient, yes, you can take a nap if you really need it. And if you're able to take a nap and wake up and feel a little bit more rested, that's normal fatigue from chemotherapy. If you're finding that you can't stay awake or can't do any activities during the day and your fatigue is just way too much, you need to talk to your provider. Maybe your blood counts are low, maybe you're a little bit anemic, maybe you need some iron supplements. So focusing on that and focusing on staying as active as you can. And there's data to show that the more active patients stay during chemo, the better they do in the long run. We know that all patients will have some decreased appetite. Many of my patients come back and say, I never really lost my appetite. I actually gained weight during chemo. Well, that can be normal. You may have a few days where your appetite goes down. You don't feel like eating. Things that you liked before, you might not like. You might have craved, steak in the past, and now you don't even want to look at a steak. Eat for your taste. Do the best you can with eating. Keep things in the house to snack on, small, frequent meals. Know that you're going to have a change in taste. A metallic taste is what patients report. So finding things that, maybe have a lot of flavor or don't have a lot of flavor to kind of appease that. And good mouth care, brushing, flossing, mouthwash is all really important to keep the mouth in check. So you may lose a little bit of the appetite for a few days and then hopefully get it back. Focusing on eating healthy things too, because now we want to work on keeping our bodies as healthy as we can. We don't have to go to the extreme. Certain people do, of course, but I use the 80-20 rule. If 80% of the time we eat pretty healthy, we can cheat or maybe not do as much on the other 20%. When I have patients go full force and we'll do smoothies and shakes and organic stuff, it's really individual. There's not a lot of data to support one way or the other, but I think just the 80-20 rule, focusing on eating more fresh foods over prepared foods will definitely be, beneficial in the long run. Peripheral neuropathy. This is the biggie. This is the one that can be long lasting, come on during chemotherapy, never go away, and can cause a lot of problems. So what is peripheral neuropathy? It's an effect to the nerves in the hands and feet, causes numbness, tingling, pain. People say it's like they have a sock on their foot at all times, or like I'm stepping on rocks, or I have something in my shoe. For those of you out there in the audience that might have gone through chemo and experienced peripheral neuropathy, please chime up during the questions and answers. Tell us what you might have felt. Well, what we've learned now with peripheral neuropathy, we can't always prevent it, number one, but we can help minimize and decrease some of its effects. So number one is we do recommend vitamin B6 during chemotherapy to be taken every day during chemo, 100 milligrams. We do now start supporting the use of icing the hands and feet during chemotherapy. And it's really starting to show, and I don't know if there's any real clinical studies, do you out there yet? It's getting there, right? That icing our hands and feet can actually minimize peripheral neuropathy. And I've started to use it on a regular basis with our patients. And they've come back and said that peripheral neuropathy is a lot less or none at all. There's ice gloves and socks that you can buy from Amazon. I'm not supporting Amazon here, but just saying it's a lot easier to get them from Amazon. And you can bring them to chemo and they can be cold and you can kind of change them out and so forth and so on. I tell my patients to moisturize and kind of massage their hands and feet on a regular basis. You know, that can also help. And then there's also medications for peripheral neuropathy that we can prescribe for you. Things like gabapentin and Cymbalta. Of course, many of my patients will say, I don't want another medication on my plate. So please, you know, can we wait for that? And we say, certainly, let's monitor things and see how they go. One of the last things that we focus on, and these are just really the top few things. I mean, there's lots of side effects, but these are the top things, is decreased blood counts. Red cells, white cells, platelets, they can all go low. A few patients might need a blood transfusion or the chemo to be held or another supportive medication to help with their white blood cell count. So those are kind of some of the top 5 things that we see that have to be actively managed on chemotherapy. Well, what is immunotherapy now? I've heard this term immunotherapy thrown around. I want immunotherapy for my cancer. Why can't I get that? Well, we always start out with the standard of care is the chemotherapy, and that's the Taxol and carbotherapy. But now we're finding immunotherapy is coming into play more so in endometrial cancer than ever. And it's a medication that basically works with your own immune system to fight cancer. And I have to say, it's pretty awesome. We're doing a lot of studies at NYU using immunotherapy. And now we have gotten the FDA to approve actually some of the immunotherapies. Some of the immunotherapies are determined by what the genomic makeup of your cancer is. That's a little more detailed. I might not get too much into that, but if anybody had questions about like foundation medicine testing, we can certainly talk about that at the end. But immunotherapy is a medication that works with your own immune system to actually fight the cancer. So some of the ones that we commonly now see in uterine cancer is pembrolizumab or Keytruda, nivolumab, or dostarlimab. Dostarlimab, I'm happy to report, has now been FDA approved for the treatment of uterine cancer. So you're going to see these coming out more and more. Sometimes some of these are combined with oral agents in some of our clinical trials even, or actually some of our FDA-approved treatments have now combined some of the active immunotherapy agents with an oral agent. I think it's lenvatinib and lucitanib. I'm just going to throw them out there. If you've heard of them, if you have questions about it, we can talk about it at the end. Well, what we want to try to do with immunotherapy is attack the cancer in 2 different ways. So we fight the cancer using your own immune system, and then we attack the cancer cell itself with an oral agent. So the cancer is getting fought in 2 different ways. So of course, immunotherapy doesn't come without side effects, and we're going to talk about that next. So some of our adverse events for immunotherapy, side effects of immunotherapy. Well, most commonly what we see is inflammation because we're activating our immune system. We're kind of turning up the dial on our immune system and making it go at 150 miles an hour to fight the cancer. So what happens to that? Well, it affects many body systems, skin, thyroid, lungs, the gut, body aches, things like that, or muscles and joints. So I'm going to break each one down. So skin rashes, most common, adverse event that we see. Someone will come in with rashes all over, rashes in one spot, very itchy sometimes. And, we're going to talk about management of all these at the end, but that's one of the common things we see. So if you're on immunotherapy and you have any type of skin rash, you got to bring it to the attention of the provider. Thyroid dysfunction. Somehow it flares the thyroid and causes patients to go more into hypothyroid than hyper, but it can go either way. If you're not immunotherapy, your thyroid function levels should be checked pretty much at every visit or every other visit, so we can be monitoring them. Because once they become abnormal, you might never have ever taken any medicine for thyroid dysfunction, but now need to take it on a regular basis, and that'll be monitored closely. Pneumonitis, so that's when we see an inflammation in the lungs. It's associated with cough and shortness of breath. It's pretty rare. I've seen it maybe 2 or 3 times in a severe case, Erin, too, right? It's the one that sounds the scariest when we're counseling patients on immunotherapy, But it's the one that becomes very acute and severe, needing hospitalization and treatment with steroids, which I'll talk about in a minute. Colitis. I have pain and frequent bowel movements, so frequent diarrhea. And that's the immunotherapy kind of reacting with the bowels to cause an inflammation reaction known as colitis. Myalgia, and I forgot to add here, arthralgias, body aches, joint pain, stiffness, to the extent that I have patients who'll come in and say, I can't even walk, I can't even move. My body is so stiff, I'm in so much pain. Well, the good news is with all of this, although it sounds awful and you think to yourself, no way do I want immunotherapy. Well, there's one drug that actually fixes all this. And it's the use of high dose oral steroids, typically is for the treatment of immune related side effects. And it's prednisone and it's measured, it's weight based. So we give 1 milligram per kilogram. So it's based on your current weight. So the treatment is one medication, typically. I mean, sometimes you need pain medicine or creams for the skin, but it reverses the immune flare from the immunotherapy. Unfortunately, it's not without side effects itself. So it's high dose steroids. So it's a very high dose on a regular basis, for could be a few weeks at least. And then you taper the dose from there until the effect is reversed. And then a decision has to be made whether you restart the immune therapy or not. Many patients will flare, have an effect, go on steroids, reverse it, improve, and be able to go back on treatment. Patients like you guys need to be closely monitored. You need sometimes a rheumatologist to help out with that, a gastroenterologist. We use our dermatology team a lot. We use an interdisciplinary team to help manage the immunotherapy side effects. So they sound scary when I'm teaching my patients all about that you're going to go on this immunotherapy and these are things that can happen, but I can fix it all with steroids. But they have, of course, we know steroids can increase your appetite. You're afraid of gaining weight. They can screw with your diabetes and raise your blood sugar. If you have any kind of injuries or wounds, they might affect the healing. But in the end, they work to reverse the effects of the immune-related side effects and can actually get people back on immunotherapy to continue to treat, their cancer. Also, if any of you in the audience are on immunotherapy, please make sure your provider gives you an immunotherapy card. It lists out which immunotherapy you're getting, when it was started, if you're taking any additional medications along with that. And we tell our patients to, when you get care anywhere, no matter where you go for what you're doing, you have to show them that you're on immunotherapy. Because just because next month you're finished your treatment with immunotherapy, your cancer's cured, you're all good and whatnot, these side effects can come up months, even years later. So patients, when you're out there getting care elsewhere, anywhere else for anything else, everyone needs to know that you've gotten immunotherapy at some point during your cancer treatment. We're kind of wrapping up here, right? We're doing good, 6:43, pretty much close on time. So I know we talked about a lot. We talked about surgery. We talked about some chemotherapy. We talked about immunotherapy. We talked about some of the highlights of, what to expect from side effects. But what are the take-home messages tonight that we want you to be aware of? Well, I want you to be aware of changes in your body, awareness of changes that are going to go on, small or big. Go see your gynecologist if you're not sure. Is it something more serious? Get them to refer you to a gynecologic oncologist when it's appropriate. Don't wait. Don't say, oh, I'm too busy. I have to, go to this meeting, or you got to take care of yourself. Erin said that multiple times. We have to take care of ourselves. As busy, active, working women, we often don't take time to take care of ourselves. So be aware of things that are changing, things that don't seem normal. It may not just be menopause. It may be something more than that. Pay attention to being, persistent things that are going on for longer than 2 weeks, and be a proactive patient. Go see your gynecologist and say, something just isn't right. I heard this talk. I know these symptoms might not be normal and they've been going on for 2 weeks or longer. I need to talk with you about it. And what do you recommend we do? And then we obviously are going to tell you, seek care from a gynecologist or a gynecologic oncologist, when appropriate. Be your best advocate for yourself, for your family members, for your daughters, your cousins, aunts and uncles, whoever they may be, because now you're armed with a lot of good information tonight, and you'll be able to access some of this information and listen to our talk. So if you're not sure I missed something, you'll be able to, I heard it's recorded, go back and listen to it. and, maybe get some information that you might need for a friend or family member. But be proactive, be aware of your body, and seek the care from the appropriate provider when it's necessary. I know we talked about a lot. We just want to say thank you for taking the time out on this Monday night of summer, for being here and hanging out with us. And we're going to turn it over now for, I guess, questions and answers. And hopefully you guys enjoyed our talk tonight. We thank you very much for participating.
Thank you so much, Kathleen and Erin. That was great. And now I'd like to introduce my colleague, Nefertiri Moore, who will moderate the Q&A session. Nefertiri, as many of you know, I'm sure, is the Outreach and Uterine Program Coordinator at SHARE, and she manages our uterine cancer helpline and all our uterine support groups, and is a uterine cancer survivor herself.
Hello, everyone. Thanks, Kitty, for the introduction. I'm going to start off, with some of the questions that have come in live. Really great questions come in. So this first question is, this person is in a study of a first-line treatment for papillary serous endometrial cancer, and in which they say that they're getting Taxol and carboplatin, and they think Keytruda, and have developed blurred vision and increased numbness in one foot, which already had numbness. And they want to know, are these side effects likely to be reversible or irreversible?
Oh, that's a good question. Okay, so I think we know about that trial too. I think we're doing it here.
Also, sorry,
But,
just really
yep.
quickly, just also keep in mind that we are not here to provide medical care to any of the participants tonight. Our goal is to really just provide education and then also encourage you to talk to your provider.
Yeah, no, that's a good point, Erin. Well, in regard to the question, certainly we've talked about neuropathy, which could be what you're experiencing in your foot. So again, we gave information about how we manage our neuropathy. So if maybe some of the things that we talked about would be helpful, vitamin B6, icing, lotioning, massage. I had patients do acupuncture when the neuropathy got bad too.
Physical therapy.
Something
we
Yep,
strongly
we often
encourage.
prescribe patients for that. So certainly talk to your provider about those things. In terms of blurred vision, I definitely would talk to your provider. I would see your ophthalmologist for an evaluation, see what's going on. I know that Taxol it's a rare side effect, but can affect vision. So I would definitely, talk to your provider who's given you the chemotherapy, to help kind of manage those things. But now at least you're armed with some information on the neuropathy and helping to manage that.
Thank you for that answer. So this next person says that they've done 6 rounds of chemo and just finished the 4th round of Keytruda, and they're having extreme constipation. And at night they take 2 capsules of Colace, and they're drinking plenty of fluids. And they would like to know if extreme constipation is a side effect of Keytruda.
Not typically from what we've seen. But again, these immunotherapies have not been around for too long. So long-term use could, slow the gut down. I would say that they probably need to talk to their provider about a more aggressive bowel regimen, not just Colace, which is a stool softener. Some natural remedies that have come up that I'd like to share with patients are using, prune juice with warm water. I have another patient that swears by aloe juice, but I would definitely talk to your provider and, figure out what's the best bowel regimen for you, in addition to the Colace that you're already taking, to help that. You definitely should be able to help it and stay on the Keytruda so you're not so uncomfortable.
Appreciate that answer. So this next question is asking, how can masturbation help in women with who are menopausal, post-surgery, chemotherapy, radiation, and remission recurrence as well?
So one of the things, especially for women who receive radiation therapy with uterine cancer. Often it's what we call brachytherapy, and it's radiation on the inside of the vagina to the, what I talked about earlier, the cuff or the incision within the vagina. So often in terms of keeping the vagina open, moist, receptive, things like that, we will recommend that patients use a vaginal dilator. That can be strictly for function. It can be a medical purpose, but also things like for our patients who don't have a current active sexual partner, masturbation is also incredibly helpful. And why? A, it's pleasurable, so it helps with a lot of the symptoms related to menopause. And B, it also can help with increasing blood flow to the vagina. And that is incredibly helpful with reducing dryness and some of the symptoms.
Yeah. Okay, so this next question says, do you still have to continue to see a gynecologist after having a hysterectomy and having cancer treatment?
Yes. That's a,
Yes.
yeah.
Yes,
That's
but
a
it
big question.
depends.
Yes, the answer is yes, yes, yes. You still need to. Okay, so you've had a hysterectomy, you've had a diagnosis of cancer. You may or may not need a treatment for it. And you've gotten to the point where you're in what we call surveillance or survivorship mode, right? Where the cancer's gone, you're cured, everything's good. You still need yearly GYN exams. You still need someone to kind of follow, making sure you're getting your mammograms and bone density scans. So yes, you need at least a pelvic exam every year. You do not need a pap smear once you've had a hysterectomy and the cervix is removed, unless you've had a history of abnormal paps or a history of cervix cancer, which isn't for this talk. But yes, you need to see a gynecologist once a year. Please, please stay on top of that. It's important because other things can be picked up along the way.
Thank you. So this question comes from someone who has had surgery as a first line of treatment and chemotherapy with radiation as well. And the question is, are there any immunotherapies approved or being tested for the use after first line of therapy to reduce the risk of recurrence?
There's not, so, okay, so that's a good question. So you're talking about maintenance treatment, basically. So we're involved or just getting going with a trial that looks at an oral agent for maintenance therapy in uterine cancer. It's not directly an immunotherapy. So immunotherapy isn't designed as maintenance yet. In some of our trials it is, but it's not been FDA approved. So yes, in some of our trials, we are, doing the Taxol carbo, and then plus or minus, meaning it's placebo-based, an immunotherapy drug that is continued in the maintenance period, but there's not necessarily an FDA-approved immunotherapy maintenance yet. I think it's coming. Once some of these trials are completed, we've enrolled thousands of patients. So I think it's definitely coming, kind of similar to patients if they know about ovarian cancer maintenance and the use of PARP drugs. It's kind of along those same lines. So it's definitely coming, and I'm excited probably in the next year or so to really be able to offer that to someone, as maintenance, because we know that maintenance therapy now in cancer treatments is important. It's almost like turning it into something chronic to take a medication to keep the cancer from coming back. So that's a great question, and then hopefully in the next few years we see something more definitive and FDA approved.
So the next question, this person says that, they've lost 10 pounds since having a hysterectomy, and they would like to know, how can you best manage weight loss from the cancer itself and being on the lymphedema treatment?
Is it, I'm a little unclear. Is it intentional weight loss? Like they are intending, they want to lose weight. They have been told that that would be helpful.
I think it's because of the loss of appetite that they've lost.
Okay. So the loss of appetite Kathleen talked about is very common during chemotherapy. Typically, most of our patients find when the chemotherapy is ended, slowly things like their taste returns. There's a lot of things that patients are adverse to during their treatment, and that usually dissipates as time goes on. So if they're continuing to lose weight though, once they've completed treatment, that is something they need to talk to their provider about.
Yeah, they can consider maybe seeking the help of the nutritionist who might be on their team. We use an interdisciplinary team with nutrition involved on a regular basis. You know, we often tell our patients when they're losing weight and we don't want them to how to increase their calories, boost, ensure, those kind of things might help, but definitely talking to their provider is the first step in, you know, being clear that this could be a problem.
Thank you. And then this next question says, how can the side effects of menopause, such as hot flashes, night sweats, and insomnia be managed after having had surgery and then chemotherapy?
So we'll often, as I talked about, some patients may be a candidate for estrogen-based therapy, but we often will use alternatives. There are certain sleep aids, some that are sold over the counter and do have minimal side effects, things like melatonin, which is what our body typically produces. We often will talk to our patients if they're a candidate to take things like Tylenol PM or Advil PM. There are, I know in New York, it's very popular to get CBD with melatonin. I think there are a lot of really good over-the-counter options that may help with sleep. Patients often require a prescription medication, and that's something, sleep is important. It's when our bodies heal, and we need it. We need good, solid rest. And so having an open dialogue with your provider, and if it's not your GYN oncologist, maybe it's your internist, about how you can get the best sleep possible. And that may include medication therapy. I'm also a big proponent, as I talked about, of exercise. We know that that helps with sleep and with rest. And then, especially during the hot summer months, taking a lukewarm or a cool shower, being in the water for at least 10 minutes prior to bedtime, clean linens, light clothing, layers, having options, a bedside fan, all of those things, you kind of find what works for you and what does not work for you. But I'm a huge proponent of sleep. We need it and we don't get enough of it.
Thank you for that answer. This may be the last question. Have there been any reported side effects from patients in uterine cancer clinical trials that you've run at your institution?
Can you repeat the question again? Side effects from
Clinical trials.
Yes, that you've run at your institution.
Yes, there are, as
well, there's a lot of
unfortunately, there are a lot of side effects,
right?
Not only related from
chemotherapy, immunotherapy. I mean, I've listed out the big ones that we see. There's certainly outliers of side effects that don't occur as often. We've probably seen about everything that you could, think of. Certainly, I'm sure patients can share with us. They would, tell us some of the other things that they've seen. But yeah, I mean, there's side effects from chemo, from immunotherapy. We, being a big, institution, we do a lot of clinical trials. So, we see the gamut of things that can go on. Can they be life-threatening? Sometimes they can. But it's active management of these things and working closely with your provider when you have concerns is most important.
Appreciate the answer. Thank you, Kathleen and Erin, for an informative program, and thanks to all of you for participating and submitting questions. Please take a moment to fill out the survey at the end of the webinar. This survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. Thank you and have a great night, everyone.
Thank you so much.
Thank you guys. Have a great night.
Bye.